Hello. It is a rainy day here today, and I am studying up on the new asthma recommendations. COPD has changed a lot in the past few years, and I would say definitely for the better. So, these new guidelines I'm going to go over in this video just specifically for asthma, which is now bundled under COPD. As where before it was kind of emphysema, chronic bronchitis, and then COPD over here, we're kind of putting them together, and the treatments are pretty similar. So I think thinking of it kind of as being a very similar condition is a good thing. The only really positive difference when it comes to asthma is that asthma is reversible. You can see long-term damage from asthma if you don't treat it. You're going to get scarring, but really other than that, you wouldn't even know somebody was an asthmatic unless they were sitting in front of you having an exacerbation or they told you. So really with decent control, these people can be happy and healthy forever. So the treatment that's proven to be the most effective is the inhaled corticosteroid. And inhaled corticosteroids are definitely the first step of treatment. The names of the inhaled corticosteroids are bumethazone, fluticasone, bechamethasone, and mamamethasone. So you're going to start out with a low dose of inhaled corticosteroids with these patients in conjunction with a short-acting bronchodilator, a short-acting beta agonist. So we call those SABAs, and SABAs are either albuterol or levoalbuterol. They are really similar costs, like about $45 to $55 for a meter dose inhaler of either. And they are incredibly similar, not just in their complex, but also their effectiveness and their side effect profiles. One thing to note is that the brand version of levoalbuterol, which is Xopenex, is a favorite among parents of children with asthma, and that is because you are going to get a little bit less tachycardia when you use Xopenex. So if you're giving a short-acting beta agonist, you're going to expect the patient to have like a heart-pounding tachycardia, experience just a lot of energy. And if you're a kid, you don't really know what's going on. So you can say to an adult, this is how you're going to feel. These are the side effects you're going to feel when you take your albuterol. But with a kid, you can't really explain it. So they don't know what to do. They just get really excited and run all over. Does not really help the asthma. But SABAs are a keystone part of treatment because they start working in about 5 minutes. So if you're having an asthma attack, this is the medication you're going to reach for. The peak of the medication is within 30 to 60 minutes, and it does last 4 to 6 hours. So if you were having an exacerbation, you would go get your albuterol. You can have either a nebulizer treatment, a meter dose inhaler, or a meter dose inhaler with a spacer. Meter dose inhalers are very effective ways of getting medication into the lungs. They're found to be like about 20 to 30% more effective than if it was a systemic medication, and even more so with a spacer. We used to give spacers just to children, but now they are being used for everyone because it doesn't help you much if your medication's just sitting on your tongue. In fact, that causes thrush. So not only did you not get the medication where you needed it, but you will potentially cause yourself to have an infection because the albuterol is just sitting there. So you've got your patient set up with a fluticasone, a betamethasone, a low-dose inhaled corticosteroid. They've got their SABA. The inhaled corticosteroid is going to be their everyday treatment. And it doesn't come with the same side effect profiles that you would expect from an oral corticosteroid. In fact, it has hardly any of them, and they are shown to be the most effective treatment for asthma. Now, what if you have a patient who doesn't respond well to just the low dose corticosteroid? So same as COPD, you're going to move to a moderate dose inhaled corticosteroid or a long-acting beta agonist plus keep the low dose inhaled corticosteroid on board. And these most recent guidelines have shown that adding the LABA to the low dose inhaled corticosteroid is going to be really your best option. First of all, you're not going to get when you go up and up and up on a medication, you get side effect. So you're not increasing it so much that you're gaining a lot of side effects, and you have the added control of the low dose beta agonist. Now, what is the low dose beta agonist? So it's the same thing as albuterol, but its action is for 12 hours. So you're not going to get any tachycardia, you're not going to get any heart pounding. But on the flip side of that, when you are undergoing an exacerbation of your asthma, it is not going to help you. You're having an asthma attack, it will not help you. And that is very confusing for a lot of people because it is the same medication, right? So the long-acting are formoterol and salmeterol. And those all have black box warnings on them right now saying, hey, if you reach for this during an asthma attack, you're going to die. I mean, and it doesn't really say it it says it more like, you know, these have an increased risk of death. It doesn't really explain that it's just because people don't understand that that's not the right inhaler to be using when you're having an exacerbation. So make sure your patients use that. If you have asthma, make sure you know the difference between your short-acting and your long-acting. And the way you can explain that to patients is by using an asthma action plan. Okay, so the other thing is, if after you've moved up, you know, added the LABA to the ICS, you can go up on those doses, but if you feel like, you know, this patient's just having a really bad exacerbation, you're not feeling good about it, you've moved up on the doses, you might choose to use an oral corticosteroid, and those have been shown to be very effective for exacerbations. They no longer require tapering. They used to require tapering, but no longer. So your dosages for that is going to be 1 to 2 milligrams per kilogram, and that's for 3 to 10 days in kids. Then 40 to 60 milligrams per day in adults. 40 is kind of the like sheepish, scared nurse practitioner dose, but no harm in that. There are going to be really no side effects. I mean, the patient might be eating more and feel like they might have more energy, yes, but are they going to have any adrenal side effects, adrenal suppression or anything like that? No, so that's why you don't need to taper anymore. An interesting thought about the inhaled corticosteroid that we've recently come across is that smokers are going to have a decreased response to the inhaled corticosteroid. This is because we're finding that they just have so much scarring in their lungs that no medication is going to be helpful to them. Additionally, Black children are going to be found to have a decreased response to inhaled corticosteroid, and we think it has something to do with their T cells being a little bit different in response. The last thing I want to mention is the exercise-induced asthma. Now, leukotriene receptors are always an option if your patient isn't tolerating the inhaled corticosteroid. It is a lot easier to use and it has good similar control. When we've done comparison studies between the leukotriene receptors and the inhaled corticosteroids, we're finding that inhaled corticosteroids are the best, but leukotrienes do very, very well. Their side effect profiles are a little bit more complex, but for people who have exercise-induced asthma as a big part of their diagnosis, a leukotriene receptor might be your first choice. And those medications are Monocast. the end of the drug is KAST, and that's singular monocast, or xyphocast, and that's actuate. So just keep those in your mind. And then the other thing to really keep in your mind, last thing, is every time you have these patients come into the office, ask them to show you how they're using their inhaler. Ask them how many times they're using their inhaler. Ask about the environmental control, and make sure that their comorbidities are under wrap. All right, so I think that wraps up the new guidelines for asthma. I hope that was really helpful, and have a wonderful day.